because we'll be recording today's session. And then, as I mentioned, you'll get that 10-second countdown, and then you can just get going, Jeff.
Great.
So thank you all. We're going to have a great session today. I'm really looking forward to listening in. And yeah, thank you for all your hard work and helping getting this put together.
Thank you.
Thank you.
Thank you for all you've done.
Our pleasure. All right, Jeff, we're good to go.
Hello, and welcome to today's education session, Thriving While Aging with HIV, Improving Physical, Mental, and Emotional Fitness. My name is Jeff Berry, and I'm co-founder of the Reunion Project, the National Alliance of HIV Long-Term Survivors, and editor of Positively Aware magazine, published by the AIDS service organization TPAN in Chicago. I'm also a long-term survivor of HIV and really happy to be here today. This program is delivered in partnership with the Reunion Project and provided by Prime Education through educational grant support from Gilead Sciences. Next slide. So I'm really excited to be joined here today by two amazing individuals. Our expert physician leading today's session is Dr. Jonathan Applebaum, who I'll allow to briefly introduce himself to the group. Dr. Applebaum.
Hey, Jeff. Thank you, and I'm pleased to be here. And I'm an internist geriatrician and long-term HIV treater. And you can see that I'm from the Florida State University College of Medicine in Tallahassee.
Thank you, Dr. Applebaum. We're also joined by Bridget Picot, our patient advocate and expert in her own right, who has agreed to share her perspective with us all today. I'd like to ask Bridget to briefly introduce herself to the group as well. Bridget?
Hello, everyone. I'd like to thank Prime for bringing me here and the Reunion Project. Definitely pleased to be here. I am a nurse living and working in Palm Springs, California. I'm a certified AIDS care nurse, and I am president-elect of my local ANAC chapter. And I also do really amazing work with the Well Project, which is specializes in HIV care for women and girls vulnerable to and living with HIV. So thank you for having me.
Great, thank you, Bridget. Next slide, please. So Prime is the accredited provider and reviews all disclosures of relevant financial relationships and resolves any potential conflicts of interest as part of its educational planning process. The content of this webinar has been vetted through a rigorous process of peer review by experts representing the intended audience. Next slide. So closed captioning is available on this webinar. So attendees should be able to see a CC or closed caption button on the top right of your screen. And so you can select that if you want to use closed captioning. Looking at the navigation panel, if you open your chat, you'll see that the first sub-tab is public, and that is questions or comments submitted in this sub-tab will be seen by all attendees and presenters. So please submit your questions or comments at any time, and we'll try to get to them as time allows. The presenter sub-tab questions will go directly to the expert faculty and myself. It will not be visible to other attendees. In the private sub-tab, these messages go directly to the Prime support staff and will be only visible to Prime. This should be used for any issues that require troubleshooting. So poll questions will pop up pop up on your screen throughout today's program, and we encourage your participation as we really want to hear from you. So once a poll has ended, our experts will discuss the results, and we'll encourage any comments to be submitted in the public chat box to add to that discussion. You'll receive a gift card for today's program. In order to receive it, please make sure you've taken the pre-survey, which you should have taken before you got on this webinar, and then the post-survey at the end of the session. And you'll also have to actively participate throughout the presentation to get that gift card. Today's program slide deck and best practices in troubleshooting for this platform are available for you to download under the Handouts tab. And please be sure to refer to this guide to assist with any answering or troubleshooting any technical issues you may have. Again, you can also send a message in the private chat tab to the Prime team if you're unable to resolve an issue. So at this time, I'm going to turn it over to Dr. Applebaum.
Okay, and go ahead, Jeff.
Yeah, go ahead.
Okay,
so I think I had this slide, but you can go ahead and take it.
Thanks, Jeff. So the goals for today, we're going to learn more about HIV and the principles of HIV management in the context of aging. We're going to explore options to adjust your HIV treatment plan to account for chronic conditions and life changes. We're going to give you tips for asserting yourself as an active player in your own healthcare decisions, and then finally discuss ways to maintain or improve your physical, mental, and emotional well-being. And as Jeff had said earlier, we really want you to be active and use the chat, and we'll try to get to as many questions as we possibly can. So we're going to start off with aging with HIV and adapting to life's changes. So to start off with a little bit of demographics, this is the current information on the number of older adults in the United States who are living with HIV. The data is about 37% of all people in the United States living with HIV were age 55 or age 55 and older, and about 10% of all new HIV diagnoses in 2019 were in the age 55 or older population. And we know that people with HIV are living longer because our treatments are much better than they used to be. So this is a growing segment of the population in the United States. So we're going to start off with a polling question. Which best describes you? Is it A, I've been living with HIV for less than 10 years, B, I've been living with HIV for between 10 and 24 years, C, I've been living with HIV for more than 25 years or more, or I'm a friend, family, or caregiver of someone living with HIV?
So for me, I'm actually approaching my 10-year anniversary this year. And it'll be 10 years with HIV, and I'm also turning 50. So double milestone for me.
Congratulations.
Yeah, it looks like we have about 16% less than 10 years, 22% 10 to 24 years, 46% 25 plus years. So a good percentage of folks living with HIV for over 25 years, and then 18% are a friend, family, or caregiver of someone living with HIV.
So this is a audience who's been living with HIV for quite a long time. Okay, so let's talk a little bit about what are some of the influences in the health of older adults. And we kind of divided into two different categories. One of them is factors related to the person, and then the other are other factors related to the environment or the living situation. So some of the individual factors can be genetics. So for instance, if you have a family history of type 2 diabetes in your parents, then you have a very high chance of getting type 2 diabetes. So genetics plays a role. There are certainly age-related changes. All of us who are 50 and older can develop some arthritis, and some of our joints may ache or bother us when the weather changes. Our behaviors play a huge role. If you're someone who doesn't eat a healthy diet or smoke cigarettes, that certainly can affect your health. And then certainly any other diseases that you have are going to influence your overall health. But we also have to look outside, and some of these things are what we used to call the social determinants of health. Do you have adequate housing? Is it safe housing? Do you have adequate transportation? Do you have access to healthy foods? Do you have the ability to socialize with friends and family? And if you're someone who needs an assistive device like a cane or a wheelchair, are you able to get that? So these are all things that influence your overall health. But there are also some aging-related changes that can occur in people living with HIV, and these can affect the quality of life in us. And some of these are geriatric terms, one of which is multimorbidity, which I would define as the occurrence of multiple chronic conditions where one condition actually can affect the treatment and evaluation of the other. So, for instance, if you have kidney disease, well, kidney disease can impact your risk for cardiovascular disease. So, one disease can impact another disease. Another issue that we deal with in geriatrics is something called polypharmacy. And certainly, the more medications that you take, the greater the likelihood that they can interact with each other and, in fact, with diseases that you have. So, we have to be careful of this. The condition of frailty, which is defined as fatigue, a slow walking speed, decreased strength, weight loss, and limited or low physical activity, is a syndrome that can be seen in older people. And then finally, other geriatric syndromes like increased risk of falls, urinary incontinence, and dementia are other age-related changes that can be seen. The concern about these is that many of these conditions can actually occur much earlier in people living with HIV than in those who are not living with HIV. And we can't forget about mental and social health. Older persons living with HIV can have an increased risk of substance use, depression, and anxiety. They may not have the robust social support systems, particularly when they need caregiving, and they face social isolation and loneliness. And they're also less likely to receive mental health care than younger persons living with HIV. Stigma plays a huge role, and it can impact perception of health, healthcare, social circumstances, and certainly mental health. And many older people also face isolation, due to their illness and maybe lack of social support. And there is a huge interplay between stigma and their ability to disclose their illness and social support. And then just because you may have one stigma doesn't mean that you may not have another one. And there may be overlapping or intersecting stigma, ageism, um, living with HIV, having being of a minority sexual orientation, gender, and race and ethnicity may augment the stigma. And this can lead to prejudice, stereotyping, and discrimination. So we're going to pause here, and I'm going to pose to Bridget. What have you found to be some of the most challenging about managing your HIV care with other age-related changes?
Well, for me, so I have a little bit of anxiety in general, and I was finding myself in this place where every time something went wrong with my body, I was like, is this the HIV or is this aging? Because, in my head, I'm still young. And approaching 50 makes you look at things a little bit differently. And so it's trying to find the balance between things that are HIV related and therefore out of my control, and things that are more so related to lifestyle and habits that I can control. And that balance sometimes is really, really hard. And I think that that's a challenge for a lot of people.
And what do you worry the most about getting older with HIV?
It used to be that I would say loneliness, but I think at this point it's more so it's mental health. Like if the last few years dealing with COVID And all of the changes that brought unexpectedly have taught us anything. It is that our mental health is paramount, because there's no telling when we're going to find ourselves in the next situation. And so access to mental health care is really, really important to me. And I know that there is a shortage of providers right now. And the challenge is going to be recruiting people to get into that field so that we do have people to take care of us.
Yeah, there already are a shortage of mental health providers, and if you add in the specialty of geriatric mental health, there's even fewer providers.
Yeah, and I'm seeing in the chat that a lot of people are saying isolation and mental health, and someone also said medication management, which is the polypharmacy that you were talking about.
Mm-hmm.
So we definitely have the same theme of challenges going on.
Yeah, and someone talked about the challenges of the long-term effects of medication, which, we don't know what the long-term effects are.
Mm-hmm. Yep.
I'm going to move on here. So now we're going to kind of move into maybe tailoring your treatment to changing needs. And we're really going to talk about the concept of shared decision making. So we all know the importance of sticking to an HIV treatment plan. And we all should know that if your viral load is undetectable, you cannot transmit the virus to anyone else. And this has, I think, been very empowering, because it's one way to reduce HIV stigma, because you preventing transmission and therefore any associated fear and guilt to your partner. And it does encourage you to stay on your treatment. But we can't forget that the viral load does not equal value. And Bridget, I'm going to ask you to talk a little bit about that concept.
Yeah. So as everyone is becoming more and more familiar with, U equals U. So undetectable is untransmittable. But a very smart man said that V does not equal V, which is your viral load isn't your value. Our value is intrinsic, whether we are undetectable, whether we have a detectable viral load, really, whether we're living with HIV or not. And so it's important for people who cannot or won't, for whatever reason, reach undetectable status to know that they still have value, and that there are still other ways that you can engage in and have a healthy sex life and a healthy relationship and interpersonal interactions with other people.
Great. And, as we have on the bottom of the slide, some people can't get to undetectable, but there's still benefits to continuing your HIV treatment, because the lower your viral load is, the less likely you're going to develop drug resistance. It does improve the quality of life and improves your overall health. So we're going to kind of get a little bit into some of the factors that may make it difficult to maintain your treatment plan. So other diseases that we call multimorbidity that I mentioned before. I think the biggest issue is polypharmacy. The geriatricians define polypharmacy as taking more than 5 medications per day. When you factor in HIV, most of patients are on 2 or 3 drugs to control their HIV. That doesn't leave much room for taking care of the other conditions before you reach polypharmacy. So it doesn't mean that always too many drugs is bad, but someone needs to look at the drugs to make sure they're all doing what they're supposed to do and not causing any harm. Mental health, cognitive decline. I think many patients fear loss of cognitive function. Substance use. If you have to change your living condition for whatever reason, maybe you have to go into assisted living. That's make it more difficult to adhere to your treatment plan. Your changing financial circumstances. If you reach retirement or dependent upon Medicare and Medicaid for your health care. And then lack of transportation. That's particularly common in rural areas where they may not have mass transit to get around to get to healthcare appointments. So here is your second polling question. What is the biggest challenge you face in continuing your HIV treatment plan? Is it A, getting to appointments, getting to prescription refills on time? Is it C, taking your medications as prescribed? Is it D, finding a provider you trust in your area? Is it E, managing care and prescription costs? Or F, is it something else?
Thank you. Remember to click on the poll, provide your answer, and then we'll monitor this as the results are coming in. A lot of interesting comments in the chat, especially around. There was one comment around concerned about being on these meds for so long, but not having been tested in women. I don't know if you saw that comment. If you wanted to comment on that while we're waiting for the poll to close.
That's a huge issue. And the other issue is in older patients. If you look at clinical trials, generally, if they're in the United States, very few women compared to men. And very, very rare to have anyone in a clinical trial who's 55 years of age and older. So definitely some gaps in our research.
Definitely. And I know for a lot of women, myself included, that is definitely a concern. And, I'm an advocate for us advocating for ourselves, which means that we have to do the best that we can as women to get involved in the trials. And part of that is the restrictions that are placed on women when it comes to clinical trials. So some more work needs to be done in that arena to get us more involved.
Yeah, for sure. So it looks like managing care and prescription costs is the biggest concern for folks on this call. And, as a lot of us transition to Medicare, or, that's a huge issue. I know personally. Then getting prescription refills on time, finding a provider you trust in your area. So those are the three biggest ones. Other has a 16% are other, so there's even other concerns out there. So be free to enter those in the chat as we move forward. Thank you.
Okay. All right. So this is where we're going to kind of talk a little bit about shared decision making, and that's a concept where you and your care team work together to find an appropriate management for your HIV. So what are the benefits of shared decision making? Well, I think the biggest thing is transparency and open communication. So it improves the knowledge for the patient of the risks and benefits, but it also gives the patient a voice to voice their preference that may help shape the outcome and the final decision. There's better confidence in the healthcare decisions and your team, and better engagement of the patient in disease management. So, as someone on the care team, I'm guided by, what do the guidelines say? What is my, many years of experience in caring for persons living with HIV? What's the clinical evidence? And what are my goals? Okay. But the patient may have different goals. And what is their lifestyle? What do they value the most? What are their preferences? And finally, we need to think about in this era of limited resources, what are their resources? So really, I like the bottom line that engaging in shared decision making can help you navigate the challenges that arise during aging with your healthcare providers. Important to have that two-way conversation with your healthcare provider.
Definitely.
And this is something that the geriatricians, this is sort of a tenet of geriatrics, the 5 M's. The 5 M's are mind, mobility, medications, multi-complexity, and matters most. So the mind is we want to maintain the mental activity of our patients and deal with what we call the 4 Ds: depression, delirium, and dementia. And sometimes it's very difficult to figure out if a patient has one or more of those. Mobility, we want to make the patient more functional, so we want to do everything we can to improve gait and balance. Falls are a huge issue in older persons, and we want to prevent falls before any injury occurs. Medications, as I mentioned before, polypharmacy is a big issue, and so optimizing the prescriptions, making sure that There's an indication for every medication the patient takes and make sure it's the best medication for that patient. And we want to always try to reduce the number of medications and side effects. Multi-complexity is really how do you manage multiple chronic conditions? Dealing with just one condition when the patient has 5 may actually make the patient worse. So we really want to make sure that we kind of navigate how the different conditions interact with each other. And also take into account the living conditions because they're impacted by age, health, and social concerns. And then finally, what matters most, and this is really where I think shared decision making comes into play. We always talk about advanced care planning, living wills, healthcare power of attorneys, healthcare powers of attorney. But we really need to find out from the patient what are their goals. Their goals may not be the same as the provider's goals. And so we need to listen to our patient and we need to include them in decision making around what matters most. And this is just a schema to show you that the healthcare team it is not just the HIV provider, but it can include the pharmacist, the peer navigator, support groups, family and friends, maybe an occupational or physical therapist, a caseworker, or social worker. And this team may ebb and flow. There may be more or there may be fewer of them. So just a couple of tips that I try to tell my patients or encourage my patients to do is when they come in to see me, every time they come in, I want them to bring in all of their medications. I call it brown bagging. Put everything from their medicine cabinet, kitchen table, supplements, vitamins in a bag. It's really important for your provider to see exactly what you're taking. Unfortunately, there may not be communication between your primary HIV provider and any specialist that you're seeing. We also want to know, what supplements and natural products you're taking because there can be interactions between those and other medications that you're taking. It's important to tell your provider what your daily schedule is like and what your lifestyle is like. We can't always figure that out. And obviously, if there's any concerns around your ability to manage your HIV regimen, we definitely want to know. And if you don't leave the office with written instructions on what medications to take when and how much, that is really, really important. And make sure that you tell us if there's any side effects or problems taking the medication at every visit. So, Bridget, we're going to toss this to you. What can your HIV care team do better to include you in shared decision making?
So the big thing is remembering that people's situation changes, right? So you may have a patient who's been stable for 10 years, undetectable. They come to all of their appointments, but something may have changed in their personal life that affects how they're taking their medication or if they have access to their medication. So it's important to remember that people's life situations change and you have to ask those questions. And it has to be more than just the cursory, how are you doing? I'm good, keep moving. It needs to be an open conversation, a back and forth, so that number one, the trust remains the same. And number two, the biggest thing is your clinician can't fix what they don't know. So if you're not letting them know what's going on with you, then you're missing opportunities maybe for them to be able to help you out with wraparound services.
Yeah, great. And what do you think is important to discuss with or ask your HIV care team about aging?
So some of the things that you were talking about are really important as we age. The issue of frailty and the issue of gait and cognition. I do nursing work with home health patients. And like you said, falls are a huge, huge thing. And unfortunately, in some cases, once you have one fall, it creates a spiral unless you do all of the work and put in all of the things that you need to put in. So it's really important to make sure that you're staying on top of, is there testing available? Bone density tests, for example. Are there services that I'm not taking advantage of, such as there's a lot of medication management programs, but some of those programs offer things like balance classes. So it's important to ask what other services are available to help you with the things that are concerning you as you age.
Excellent. So now we're going to switch to treatment options that work for you. So our third polling question, aside from efficacy, what's the most important factor in your HIV treatment decision-making? Is it pill size, B, the number of pills per day, C, the side effects in the pills, D, the interactions with other medications, E, the potential impact on other conditions, F, drug resistance, or G, the cost of treatment?
A lot of options there.
I know for me, I changed my last regimen related to side effects. So I do want to mention that it's important for patients, if something is not working for you, just because you have an undetectable viral load on a particular medication doesn't mean you have to suffer with the side effects from that medication. There are other options available that may reduce those side effects and still keep you undetectable. So keep that in mind. That's another reason that it's important to have that open communication between you and your provider.
Yeah, I absolutely agree with that, Bridget. We have lots of options these days. It's not like the old days when we had very few. And I had a patient the other day who had been taking a really older regimen and basically listed every side effect from that regimen. And he did not want to change his regimen to something newer, but we finally talked about it. And, you know, over the course of a couple of visits, he finally saw that it was a reasonable thing to change. So there are lots of options these days.
Yeah. I'm seeing a lot in the chat that a lot of people are saying that their primary care doctor, for example, or their HIV doctor is about to retire, or that they're having an issue finding an HIV doctor in their area. And I really think that the concern about having enough HIV specialists able to do the work is a valid concern. Because a lot of this, a lot of the specialists are aging out, just like the patients are aging out, which is unfortunate.
Yeah, thank you. So it looks like the top response is, aside from, to the question, aside from efficacy, what's the most important factor in your HIV treatment decision-making is side effects, as we've been talking about, followed by interactions with other medications. Some of the medications that are newer, there are significant interactions. So you have to make sure that, you're reading the label and making sure that you're talking with your provider about any other medications that you might be on that could be interacting with the HIV drug that you're taking. And then potential impact on other conditions was probably the third top response to that.
That's a great point about the interactions with other medications, because Dr. Applebaum, I think you mentioned it, that sometimes there's not communication between your HIV specialist and your other clinicians that you're seeing. So patients need to take on a little bit of personal responsibility and make sure that when you see, for example, your cardiologist, if your cardiologist prescribes you a medication, that you let your HIV specialist know about it, and vice versa. And that's for any specialty, whether it's mental health or cardiology or for renal disease or whatever the case may be. You have to make sure that each of your clinicians knows what medications you're taking so that you can avoid potential problems like that.
That's a great point. And I know patients often assume that doctors communicate with each other. And in reality, having been in this business for a while, I think that communications are actually worse now than they were 20 and 30 years ago. So it is really important, as I said earlier, bringing all your medications in so that we can actually see what you're taking. I was actually surprised by the poll, Jeff, because many of us now assume with the newer regimens that side effects of the, newer HIV meds are a lot less than they used to be. But it's important for us to realize that a side effect is a side effect, and we need to take it at face value. And if it's affecting their ability to keep with the regimen, then we need to find an alternative.
Yeah, and I think some of that, that's a good point. And I think some of that could be side effects from some of the older medications that some of us are still experiencing, such as like dystrophy or neuropathy. So there's that concern because of the history of the older drugs too. Not to say that the newer drugs are completely without any kind of side effects, but it could be like a part of that is things that you're still experiencing as a result of medications that you took previously.
Yeah. And someone just put in the chat that's the number one reason why people stop taking their medications, and it's true. I think that's absolutely true.
And I think that it's important that people recognize that before you do that, before you stop taking your medication, have a conversation with someone, whether it's a peer navigator or an advocate or a friend, but mostly with your clinician. That's who you want to have the talk with. And if they're not listening, find somebody who is.
And there's a great comment. Medicare patients can request a comprehensive medication review as part of their annual wellness visit. It's covered by Medicare, so ask your primary care provider.
Right. Okay. So just important to understand that it may be beneficial or may be important to change your regimen. And so some of the common reasons for changing: side effects, as we mentioned, interactions with other medications or supplements, particularly if those other medications are important for you to keep on taking. If you have other conditions, the big one that we see is liver and kidney disease, because many of the medications we take are broken down by the liver or the kidney. And if you have perhaps age-related decrease in kidney function, that may be an indication for your doctor to change or modify your regimen. There may be issues around dosing, perhaps the number of pills or the food requirements, things like that may be a reason. Or maybe you want to change from taking the pill to the new injectable treatment. That may be a reason. And then, unfortunately, if you have a history of drug resistance in the past, that may make it reasonable, or maybe it may make it possible that you have to change your regimen because the current regimen you're taking just isn't working as well. So, Bridget, have you ever switched your ART regimen?
Yeah, I've actually switched twice in my time living with HIV. The first time was because my liver and kidneys weren't happy, and the second time was due to side effects. I had the worst insomnia and joint pain on the last regimen that I was taking, but it was working. So, and then just that fear that we have of letting go of something that's working can be a lot. And so it was a bit of a decision for me to switch, but I did, and I'm happy that I did. I still have an undetectable viral load, but I don't have the huge problem with insomnia that I had. Now I have some other issues, so it's a balance, right? There's medications just have side effects, and it is whether or not the side effect is manageable for you and your lifestyle. So I would just encourage patients to really think about that and change if you need to. You can always go back. If you're not failing a regimen and you switch, you can always go back to it if the new one doesn't work for you.
So let me ask you, Bridget, how did you and your HIV provider identify what regimen was best for you?
So we actually had a couple of conversations, like you were saying, about with your patient over a couple of visits. I am a person who believes in doing my own research. So he gave me suggestions for a couple of different ones. I went home and researched the two of them. And I would encourage people to use reputable online sites. Don't just go anywhere. And made my decision from there. So it's, again, the shared decision making. It's having the conversation and having your clinician give you enough time to think about it. It's not, you don't have to make a decision the first visit or even the second visit. You can take your time and do your research, but just have the conversation because it's important.
Great.
I want to point out a comment from someone who said that they've been on so many medications that they don't really have many options left. So, I don't know if we had a slide on that coming up. I don't want to jump the gun here, but, that is a huge issue. And I know that, there is, drug development happening for newer agents and in different drug classes, but it's hard to tell someone who needs that choice now that, just wait, there'll be new drugs coming out in the next few years.
Yeah, I mean, the good news is that there are new drug targets, not the same old ones that we've had for many years. So, and there are some that have been approved and other ones that are coming to market. So, I would encourage that person to have that conversation with their provider. And it may be like, as we talked earlier, that you may not be able to get to undetectable, but we certainly want that viral load down as low as possible.
Agreed.
Okay, and then I think this is our last section. We're going to talk about support and strategies for living well with HIV as you age. So it's just important that to know that people living with HIV are able to live longer and healthier lives. I think a lot of it is due to the improved management that we've learned about over the last 40 years. And so this is just a list of some tips, making sure you take all your medications, as I mentioned before. Bringing a list of your medications, I actually think bringing them in a bag is important. Making sure you keep your appointments with all your providers, not just your HIV provider. If you have the luxury of having a specialty pharmacist that you work with, they're really good about managing medications and giving you tips on adhering to your regimen. Make sure you have a communication with your provider and you know what symptoms to look out for and know what screening tests need to be done. Part of healthy aging is prevention also. Bridget mentioned the DEXA scan. That's an important screening test for bone disease. There are certain vaccinations that are recommended. So these are things that your HIV provider or your primary care provider, should be up on. And then again, making sure that communication that you talk about side effects, symptoms, or any problems you're having, adhering to your regimen. And then, what are some of the barriers to accessing medical care? Well, health literacy, that's not, whether or not you got a PhD, it's how well you understand, the information that you're given about your health. And it's okay to say to your provider that I don't understand what you just told me, or I don't understand the brochure that you gave me, because it's really important for you to understand everything about your health. We've talked about mental health, the need for access to food, housing, transportation, and dealing with substance use disorders. So this concept, and we mentioned before about wraparound services. There are wraparound services to help support HIV care, and some of these are services that are kind of outside of primary HIV care, and they can include telehealth, peer navigators, mental health and substance abuse services, transportation to and from your appointments, case management, access to food banks or meal delivery, and financial assistance programs. And if you don't know about wraparound services, you should be able to reach out to your local AIDS service organization. There's one around virtually everywhere in the country, or calling your local 211 number which should be able to link you to essential community services in your area.
I want to interject real quick. I know sometimes people have a little bit of hesitancy in approaching ASOs or aid service organizations because they are still hesitant about a lot of people knowing what their status is, which is understandable. There are also community-based organizations and online organizations that you can reach out to that will help you kind of protect your privacy, but still help you get the wraparound and additional services that you may need. So don't give up. That was it.
Great. So let me ask you, Bridget, what wraparound services have you used and how did you find them?
So when I first got diagnosed, I didn't know anything at all. And someone directed me to my local aid service organization. I was able to get into care. I was able to find mental health care to help me deal with, the early depression and anxiety that I had. But I also reached a point in my life where I was food insecure, and I had never been in that position in my entire life. And so my ASO was able to help me get some food cards and some gas cards, which while it was humbling for me as a person who had been working since I was 16, I also had to realize that that was what I needed at that time in my life to get me over that hurdle. And I'm forever grateful for it. And so the hardest part for people is overcoming pride and asking for that help. It's there. You just have to ask for it. It's part of advocating for yourself.
So what services would have been most helpful in supporting your HIV care and well-being?
I got them, which is the mental health portion of it. And I actually wish more so now that I had taken advantage of some of the peer support groups and things like that they had, because I think it's important for people to be able to see themselves reflected in someone else when they're in a struggle, right? It helps you know that there's hope and that you're going to get there and that you're not the only person that's going through something. And so it all kind of comes back to a sense of community to battle isolation and the mental health aspect for a sense of wholeness and completeness, and just engaging yourself persistently. Like I use this expression, persistent participation. So persistent participation in your care and finding out the services that are available to you in your area. And if there are services you need that aren't available in your immediate area, do the research, ask someone, find someone that can help you find them someplace else.
Right. Okay, so, and then we also want to not forget about mental health. So it's really important if you're feeling isolated or lonely, you're noticing that you're using more alcohol or drugs, you're having trouble sleeping, loss of appetite, can't concentrate. You really just feel like you want to stay in bed all the time because of your mood. You don't feel, interested in the things you used to enjoy, or trouble performing the daily routine. Those are all signs of perhaps profound depression. And so it's important to seek help. So where do you go? Well, reach out to your support system, your family and friends. Your healthcare provider should be aware and should be able to find services for you, or your peer navigator. Reaching out to your community, whether it's a secular or religious community, they will hopefully be able to help you. And then if you need an immediate emotional support, there is the National Suicide Prevention Lifeline, which is the long 800 number. But just to let folks know that effective July 16th, which is in a few short weeks, nationally, the number will be an easy to remember 988 number. So after July 16th, you can call 988 and be connected to local services in your area.
That's, I just wanted to mention about peer support. Back in the day when I was first diagnosed, that's all we had. right? So we didn't have any effective. We had AZT, and that was it. That by itself was not effective. And so peer support played a huge role, and it continued to play a huge role and still to this day, for helping people through a situation, having hearing your peers and sharing their stories with you and yours with them really helps build that community that Bridget you were referring to. There was a comment in the chat that a lot of the ASOs in their city have turned to the FQHC model or been absorbed by other more clinic models, and the peer support has gone away.
Mm-hmm.
And we've known that a lot of the peer support funding has gone away. And so somebody mentioned telehealth as a way for them to access it. I know this is probably really important, especially for people in rural areas. We're still in a pandemic. So telehealth plays a huge role in helping to provide support.
Yeah. And the other thing too is, I'm sorry.
No, go ahead.
The other thing too is that there are organizations that will teach you how to become an advocate and how to become a peer navigator. I know ANAC has one, for example, and I believe there's a couple of other organizations that offer, and it's basically, it takes a couple of your Saturdays or a couple of your Wednesdays, or the ANAC program, for example, is 6 months, but it will teach you how to become an advocate and a navigator, which will not only help you, but if you're one of those people with a heart for it, can also help you bring those advocacy services to your area and to your organization, as a stepping stone and as a model for them to try to adapt.
I just wanted to answer one of the comments in the chat. The 988 is a toll-free number. It's really to make it easier to access the National Suicide Prevention Lifeline rather than trying to remember that long 800 number. The number is going to be very similar to your local 211 number that you can call for community services. So yeah, 988 will be free, but it won't be active until July 16th. So some general tips on self-care: keep active, eat healthy, drink water, get enough sleep, find things hobbies that you enjoy, stay connected with family and friends, because if you feel good about yourself, that can also help your health. So Bridget, I think this is our final questions together. How do you practice self-care and make time for the things that you love?
Like I was talking about, persistent participation in your healthcare, persistent participation in your self-care. And I always point out that self-care is not just getting your nails done or buying that gorgeous pair of shoes or the new belt that you want. Self-care is also learning to identify what triggers you, what makes you feel lonely, what makes you feel angry, what makes you feel upset, and then doing things to mitigate that mental state of mind. So self-care has to be a whole approach, not just spoiling yourself with things, but also spoiling yourself mentally and emotionally so that you can stay in a good and healthy frame of mind.
So last question, what are most looking forward to as you get older?
Getting older is a blessing. Like I keep saying that I'm almost 50, and I'm a little bit surprised to find that I'm not upset by that at all. I'm looking forward to it, because the reality is, if not for a couple of decisions and a couple of intersections, I could literally not be sitting here. So I'm totally looking forward to getting older, and hopefully, prayerfully, persistently continuing to thrive as I get older, because I feel like I'm thriving more now than I was before my diagnosis, which is strange for some people, but for me, it's a matter of course. It's what you make it.
Great. All right. I'll turn it back to you, Jeff.
Yeah, thank you. Wow, what a great discussion. I know a couple of folks have raised their hands and asked if, when they'll have a chance to talk. Unfortunately, this webinar does not allow us to bring people on. So if you do want to, if you have a question, please put it in the chat. There's been a great conversation going on throughout this webinar. A lot of folks are very grateful for everything they've learned today. We've covered, and that we've covered so many topics in an hour. Personally, I didn't think we were going to get through the slides. I told you guys that a couple of times, but you did a great job. And I think that all the different topics that we touched on today are really important. And I particularly like the personal perspective that Bridget, you brought to the conversation. I was just thinking of what you said about spoiling yourself, both mentally and emotionally. So I think that's so important. Knowing as I get older, I know that it's important to be able to say no to things, and making sure that you set your boundaries and keep them, both with the relationships, but with your work if you're still working, and taking the time for that self-care, because it's so important.
I think that is an amazing point. Setting boundaries, like if you takers will continue to take. And so if you don't set boundaries, then you'll end up lost and buried under who knows what. And, that old expression says that you can't pour from an empty cup is very, very true.
A comment thanking you, Dr. Applebaum. FSU is my alma mater. So that's...
Go Knowles.
Yeah, so any other closing comments from you, Dr. Applebaum or Bridget?
I don't really have any comments. I think we talked about a lot of things, as you mentioned, Jeff. We covered a lot of topics. I too didn't think we would get through all this, but we did.
We did.
Well, I want to thank both of you for the opportunity to be here. I enjoy sharing my perspective, and I think I have a little bit of a unique perspective from seeing it from both the patient and the clinician side as a nurse. And I would just encourage everyone to persistently participate in your care. It'll make you feel better mentally and physically.
Persistently participate. That's
right.
That's a great motto to live by. Just a reminder, there is a $10 e-gift card that folks can, if you fill out the survey, there's a link in the chat. Please fill that out, and you can get your $10 gift card. I appreciate everyone staying and the great conversation. I think we had a list of resources in the previous slide, and so so folks can get these if you download the slides, or take a screenshot right now. Get your phone out, take a picture. And these are just some of the many resources that are available for folks online. And I think we had a couple of upcoming events on the next slide. Let me see here. Oh, here we go. One is for, these are both for Prime Incorporated. So one for Making Women's Voices Heard on July 19th, and then July 20th, HIV and gender affirming care in transgender persons. So those sound like great topics as well. So I just want to thank you both once again. My name is Jeff Berry. I'd like to thank the Reunion Project, our supporter, Gilead Sciences, and Prime for supporting today's educational activity. Also, give big thank you and huge shout out to our expert faculty panel, Dr. Jonathan Applebaum and Bridget Picot. And lastly, just thank you to everyone for taking the time to learn with us today, and hope you found today's program useful and informative and enjoyable. So this concludes today's session, and enjoy the rest of your day.